I would like to thank EMAS for inviting me to speak at this webinar. The title of my presentation is Testosterone and Aromatase Inhibitor Therapy in Advanced Breast Cancer, a case series. Much of the rationale supporting this presentation can be found in our recent article, Testosterone Implant Therapy in Women with and Without Breast Cancer. Throughout this presentation, I will be using several abbreviations. AI stands for aromatase inhibitor. A stands for anastrozole, an aromatase inhibitor. L stands for letrozole, which is another aromatase inhibitor. It should be noted that permission has been granted and formal releases have been signed for the use of all images or videos found in this presentation. In this first section, I'm going to discuss androgens and the breast. I will also talk about the use of testosterone and testosterone with anastrozole pellet implants in women with and without breast cancer. This is not a new concept. Testosterone, including testosterone pellet implants, have been used to treat breast cancer since 1937. However, a drawback to testosterone therapy is its propensity to convert to estradiol via aromatase, which can override the growth inhibitory effects of testosterone and stimulate estrogen-sensitive tumors. The function of testosterone at the androgen receptor. Testosterone decreases inflammation in every organ system, which is protective against cellular damage. Testosterone's function at the androgen receptor in the breast decreases proliferation and hyperplasia. Testosterone also decreases estrogen receptor alpha and increases estrogen receptor beta, which inhibits proliferation. In 2019, we published the results of our 10-year prospective cohort study, which showed a reduced incidence of invasive breast cancer in women treated with testosterone pellet implants. In invasive breast cancers, testosterone has been shown to be pro-apoptotic. It increases cancer cell death. It also decreases invasive breast cancer growth. However, testosterone can aromatize to estradiol. There is tissue-specific expression of aromatase activity. Testosterone is aromatized to estradiol, which can stimulate estrogen receptor-positive breast cancers. Furthermore, aromatase activity or expression is increased in active breast cancers. We have been using the combination subcutaneous implant since 2008. This is composed of testosterone with either anastrozole or letrozole, aromatase inhibitors. It allows a simultaneous and continuous delivery of both active ingredients over a period of about 3 months in females. It avoids the intrahepatic first pass effect. It allows the beneficial effects of testosterone while avoiding the adverse effects of elevated estradiol in estrogen receptor-positive breast cancers and other estrogen-sensitive diseases. The most commonly used combination implant in clinical practice is composed of 60 milligrams of testosterone with 4 milligrams of anastrozole. We have also used 60 milligrams of testosterone with 6 milligrams of anastrozole or letrozole. Testosterone drives the release of anastrozole. We have performed over 3,500 insertions in breast cancer survivors, and there have been no adverse drug events. Constantine and I have published several reports on the tumor response of active breast cancers to the combination testosterone anastrozole pellet implants. We have also shown a beneficial effect in the neoadjuvant setting where the subcutaneous testosterone letrozole therapy was administered before chemotherapy, and it showed tumor reduction in size. It was continued through chemotherapy or concurrent with chemotherapy and showed a reduction in the side effects from the chemotherapy. In 2014, we published data on the efficacy of subcutaneous testosterone on menopausal symptoms in breast cancer survivors. 72 patients were enrolled in the study. The goal of the study was to prospectively assess the clinical effect of the combination testosterone with anastrozole on menopausal symptoms, psychological, somatic, and urogenital complaints in breast cancer survivors. Efficacy of therapy was documented using the validated self-administered 11-item menopause rating scale, which patients completed prior to and following therapy. The mean testosterone dose was 169 milligrams. The mean testosterone level on therapy was 354 nanograms per deciliter. There were statistically significant improvements in the menopausal rating scale total score and all subscales, including psychological, somatic, and urogenital complaints. In addition, all individual symptoms or conditions, including hot flashes, improved after patients received testosterone anastrozole implants. Testosterone and testosterone anastrozole pellets were also evaluated in a randomized double-blind placebo-controlled trial in postmenopausal women with aromatase-induced arthralgias. The results of the trial were published in 2020. Patients receiving testosterone therapy, either as a gel or the testosterone anastrozole pellet implant, did report improvements in strength, lack of energy, urinary frequency, and stress incontinence. In addition, the patients receiving the subcutaneous testosterone anastrozole implants also reported improvements in hot flashes, fatigue, mood swings, urinary incontinence, skin appearance, tone, and texture. Arthralgias did not statistically significantly improve on testosterone implant therapy. The 120 milligram dose of testosterone was thought to be too low. Testosterone's effects are known to be dose dependent. We did see statistically significant improvement in joint and muscular discomfort on the 169 milligram testosterone dose.
I am a 59-year-old female. I developed breast cancer, estrogen positive breast cancer 5 years ago, and had a double mastectomy, chemotherapy, and after everything was done, I was put on some estrogen blockers, and as a matter of fact, I had tried 5 different estrogen blockers. They kept changing me to different ones. The reason why they kept changing me is because I had the most excruciating bone pain on all of them. I got to the point where I couldn't move my wrists at all. There was so much pain in my wrists and in my lower legs. I had just severe pain. I couldn't walk, I couldn't exercise. And every time I complained to my oncologist, he would just change me to another estrogen blocker. So I finally became my own advocate and started doing some research online, and found the pellets, the information on the pellets with the testosterone and the estrogen blocker combined. And I went to my oncologist 3 different times, and finally on the 3rd time he agreed to let me give it a try. He said, why not, let's just do it. So I came up here to Dr. Glaser and had my first set of pellets, and within just a couple weeks, the bone pain was totally gone. I also had just excruciating hot flashes. I could not wear shoes. If I put a pair of shoes on, a pair of socks on, my blood pressure went up, my whole body turned red. And after about 4 weeks of being on the pellets, that was totally gone. And so for the first time in my life, since I had been diagnosed with breast cancer, I felt like a human being again. I was sleeping, had no bone pain, so was able to start exercising again. My children both told me, I drive 2.5 hours to come see her and get my pellets, and I would fly if I had to get them. And both of my children have said they would drive me if they had to, because I was really at a point on the estrogen blockers where I didn't want to live anymore. I was just in too much pain and too unhappy. So based on that, sorry about that. I have none of that anymore. I have a Thrive for Life again. I'm able to work out. I don't have any hot flashes. I don't have any bone pain. And I have my life back. And I owe that all to her and her research.
We have shown that the combination of testosterone with an aromatase inhibitor can improve the quality of life in breast cancer survivors. It also confirms the direct of testosterone on these symptoms at the androgen receptor. In clinical practice, we've seen a decrease in breast cancer recurrence in patients treated with a combination implant. Testosterone alone may be contraindicated in many estrogen receptor positive breast cancer patients. It must be combined with an aromatase inhibitor. Estrogen levels should be monitored, and a low glycemic whole food diet is critical to prevent breast cancer recurrence. Testosterone and aromatase inhibitor therapy in active and metastatic breast cancer, a case series. Much of this data was originally presented at the Androgen Society meeting in 2021. Patient 1 is an 82-year-old patient who presented with a 4-centimeter palpable invasive lobular carcinoma and palpable axillary lymph nodes. It was hormone receptor positive. She was treated with intramammary testosterone and anastrozole. 3 pellet implants were placed in the breast tissue surrounding the tumor. Theoretically, this allows for a higher concentration of both testosterone and the aromatase inhibitor at the tumor site. The patient received a second pellet insertion at week 8. Here's her mammogram at baseline on the left and 8 weeks post-testosterone and anastrozole therapy. Note the marked decrease in size of the tumor. Here's her mammogram at 19 weeks post-insertion of her first implant. Both the breast and axillary lymph nodes are no longer palpable or visible on mammogram. Patient 2. Patient 2 is a 58-year-old female who presented with a 6-centimeter visible tumor with skin discoloration, which was fixed to the sternum. The tumor was actually visible through her clothing. The patient refused conventional therapy, including biopsy. She was treated with testosterone 180 milligrams and letrozole 12 milligrams inserted around the tumor in her breast. A second insert was performed 6 weeks later. She also stopped consuming sugar and processed foods. You can see the visible tumor, which was fixed to the sternum. In fact, when she sat up, the tumor would remain in place while the breast dropped. You can also see the skin discoloration where the tumor's invading the skin. This is an ultrasound of the tumor. You can see that it was actually too large to fit on a single screen of the ultrasound. Note that the tumor is fixed to the sternum and invading the periosteum. You can also see where the tumor is invading the skin. This is a follow-up ultrasound 6 weeks following her first testosterone letrozole pellet implant. You can see the marked reduction in size of the tumor. In addition, the tumor is no longer invading the skin, and there's a developing plane in the periosteum. This is a follow-up ultrasound from 8 weeks. Note the continued reduction in size of the tumor mass. At 5 months, a complete clinical response continued, and we documented a complete radiographic response. There was no evidence of the tumor on ultrasound. Note the indentation in the skin where the tumor had previously stretched the skin. At 7 months, she continued to have no evidence of disease, but began complaining of arthralgias in her hands. At that time, we discontinued letrozole and changed to anastrozole at a lower dose. She continues her whole food, low glycemic diet. The patient's symptoms completely resolved on the lower dose of the aromatase inhibitor. She remained disease-free at 18 months, and estradiol levels remained low, less than 5 picograms per milliliter. It's important to note that we were able to lower the ratio of anastrozole to the testosterone because the patient no longer had an active tumor making aromatase. The patient has remained disease-free for over 2 years. Her most recent dose of testosterone was 320 milligrams combined with 8 milligrams of anastrozole. She has remained symptom-free on this combination and dose. We've also found that combining finasteride with testosterone in an implant prevents the cosmetic side effects of testosterone. There have been no adverse drug events associated with either anastrozole or finasteride combined in the implants. Patient 3 is a 72-year-old female who presented with severe pain, fatigue, anxiety, memory issues, depression, and anemia. She's status post-gastric bypass. When I saw her the first time, she was being worked up for multiple myeloma. She was treated with 160 milligrams of testosterone and had some improvement in her clinical symptoms. As part of her workup, the patient underwent a bone biopsy. At that time, she was diagnosed with metastatic infiltrating ductal carcinoma of the breast, which had metastasized to her bones. It was estrogen receptor positive. On clinical examination, she had a palpable 2.5 centimeter subareolar mass. At that time, she received testosterone and letrozole combination implants in the gluteal area. The dose was 180 milligrams of testosterone with 12 milligrams of letrozole. 8 weeks later, there was a complete clinical response on breast exam. The mass was also significantly decreased in size on ultrasound. At that time, a second set of implants was placed. The patient's symptoms of fatigue, severe anxiety, and depression were markedly improved. She also tolerated extensive surgery on her humerus, secondary to bone metastases, without any complications. Baseline ultrasound revealed an approximately 2.5 centimeter subareolar mass. This is the patient's 8-week follow-up ultrasound. Note the marked reduction in the size of the subareolar mass. Systemic chemotherapy was recommended. The patient and her oncologist chose not to continue pellets during chemotherapy. Unfortunately, she's been hospitalized several times for complications and serious adverse drug events from the chemotherapy. The next patient is a 67-year-old female who presented to the emergency room with acute respiratory failure. Portable chest X-ray revealed bilateral nodular densities. CT of the chest confirmed innumerable pulmonary nodules consistent with metastatic disease, a large right breast mass, and axillary masses. Clinical breast exam revealed an 8 centimeter mass with skin invasion, nipple retraction, and palpable axillary lymph nodes. Core biopsy of the tumor revealed a grade 2 infiltrating ductal carcinoma, estrogen receptor positive. The tumor was actually too large to be accurately measured on ultrasound. However, we were able to identify both skin invasion and muscle invasion. The patient was initially treated with 240 milligrams of testosterone with 24 milligrams of letrozole inserted in the gluteal area. Following this, she was treated with 320 milligrams of testosterone with 24 milligrams of letrozole at 9-week intervals. She also changed her diet to a whole food, low glycemic diet from a high carbohydrate vegan diet. 4-week follow-up revealed a marked change on clinical breast exam. The breast mass and axillary lymph nodes were much smaller in size. The patient was asymptomatic and had increased energy. She had no cough or shortness of breath. She was no longer using her albuterol inhaler or oral steroids. Her O2 saturation at week 4 was 98% on room air. She also had a 4-pound weight loss and a half-inch decrease in waist circumference. At 9-month follow-up, the patient reported feeling amazing. She also continued to refuse conventional therapy. She had a 23-pound weight loss and continued testosterone letrozole therapy. 11-month follow-up revealed a stable clinical and ultrasound exam. The patient did complain of shortness of breath towards the end of her testosterone letrozole implant cycle. This was a new finding. She had mild expiratory wheezing on examination, no pain or other symptoms, and her testosterone dose was increased to 400 and letrozole dose was increased to 30 milligrams. The patient's dyspnea and shortness of breath worsened. She was sent to the hospital. Her COVID test was negative. A follow-up CAT scan of the lungs was ordered. She was eventually diagnosed with acute bacterial bronchitis. This is her baseline CAT scan of her chest, 1 year prior, showing innumerable pulmonary nodules compatible with metastatic disease. This is a follow-up CAT scan of the chest 1 year later. Although some nodules are still present, there has been considerable improvement in size and number throughout the lungs since the prior exam. This marked improvement is also seen on the transverse view. 20 months following her initial therapy, the patient remains asymptomatic. She continues her healthy diet and lifestyle. She feels great, and her O2 saturation is 98%. The next patient is a 58-year-old female who presented with metastatic breast cancer. She had bone and possible liver nodules. She had cervical spine surgery for metastatic disease. Her tumor was estrogen receptor positive. She had a 4.5 by 2.5 centimeter palpable right breast mass in the lower inner quadrant and bilateral palpable axillary lymph nodes. She had received 4 doses of IV Herceptin, which was not well tolerated and resulted in memory issues, foggy thinking. She was sick, lethargic, and couldn't function. She refused chemotherapy. The patient was unable to tolerate oral letrozole. She had severe nausea, vomiting, and abdominal pain. She also had multiple trips to the emergency room for gastritis. She had significant weight loss and was diagnosed with malnutrition. She felt miserable. We treated her with a testosterone and anastrozole combination implant. At 10 months on therapy, the patient was feeling really good. Amazing, so much better. Her dysphagia and tingling had resolved, and she was able to gain some weight. The disease was initially controlled with over a 95% reduction in breast tumor volume, and the patient had no adverse side effects from the testosterone and anastrozole therapy. This is the patient's menopause rating scale rated prior to the initiation of testosterone and anastrozole therapy. Note the severity of her symptoms. This is the patient's menopause rating scale following the initiation of testosterone and anastrozole therapy. Notice the significant improvement in all 11 categories of symptoms. The patient began having worsening left hip pain at 12 months. Radiation therapy was recommended. She received a pellet implant at that time. I'm not sure what happened, but she never returned for follow-up care, and I found out that she eventually succumbed to her disease. It's not about keeping everybody alive forever, but it is about improving quality of life. The next patient is a 60-year-old female who presented in 2015 with metastatic breast cancer. She required assistance to walk into the office. She was weak, fragile, and complained of severe bone pain. She was on Celexa, Ativan, Vicodin, Ambien, and multiple supplements. She was undergoing standard therapy, which was Xeloda at that time. She was treated with 180 milligrams of testosterone with 12 milligrams of letrozole. This is her baseline menopause rating scale. Note the severity of multiple symptoms. This is her menopause rating scale on testosterone letrozole implant therapy. Notice the complete resolution of most all of her symptoms. In addition, she was off Vicodin, Ativan, and Ambien. It's about the quality of life. This patient is almost 6 years on testosterone letrozole subcutaneous pellet implants. Her current dose is 240 milligrams of testosterone with 12 milligrams of letrozole. In addition, she continues conventional therapy. This is not a one or the other situation. She has no physical, clinical evidence of disease. The patient is thriving. The next patient is a 65-year-old female who presented with metastatic breast cancer to the bones and possible liver metastases. She had a past history of Hodgkin's lymphoma, treated with radiation therapy, melanoma, and her initial diagnosis of breast cancer was in 2014. She also had a pleural effusion secondary to pulmonary emboli. She presented with weight loss, muscle loss, anemia, and bone pain. On clinical examination, she had significant right leg weakness. She walked very slowly with a walker. She could not lift her right leg against even minimal pressure. She was initially treated with 340 milligrams of testosterone combined with 18 milligrams of letrozole, the aromatase inhibitor. Remember, higher ratios of aromatase inhibitor is needed with active disease. I saw her back 3 months later. At that time, her gait had improved. She was walking without her cane. She was driving again. She had gained weight, and her strength had definitely improved. At that time, she received 340 milligrams of testosterone with 16 milligrams of anastrozole and was eventually able to travel with her husband. I saw her back in September of 2021, at which time she was late to her appointment and actually rushed into the office. Follow-up labs at week 4 and at the end, prior to reinsertion, revealed therapeutic levels of testosterone and an estradiol level that remained less than 5 picograms per milliliter. Her anemia also improved on testosterone therapy. We also saw a significant improvement in tumor markers on testosterone aromatase inhibitor therapy. After the first insert, CA2729 had normalized to 26.3. CA15-3 had also normalized, and CEA had markedly declined. A follow-up CAT scan obtained in June of 2021 showed improvement in metastatic disease in the spine, sternum, and pelvis. Her pleural effusion was also resolving. The patient sent me an email with pictures of her trip from Italy. She was so happy that she was able to climb middle-aged cobblestone streets with steep hills and steep steps. Less than 6 months after her first testosterone aromatase inhibitor implant, when she was barely able to walk into the office with a walker, she was able to swim by herself in warm ocean water. She reported that her legs were still weak in regards to kicking, but hopefully they will be strengthened. Hormone receptor positive invasive breast cancers respond favorably to subcutaneous testosterone aromatase inhibitor therapy. This therapy has also been shown to improve quality of life in breast cancer survivors. It is inexpensive. It should be further investigated in controlled trials. These results may not apply to other doses and forms of testosterone. All patients are informed of off-label use, benefits, and risk of therapy. In addition, all patients sign written consents. Thank you for your time and attention.
Thank you, Dr. Glaser, for an amazing presentation.
Thank you,
now
Lena.
for the Q&A. Thank you. And now for the Q&A session, I remind you that you can still submit your text questions via the Q&A widget located in your control panel. All right. So our first question for you today, Dr. Glaser, is in examples like case 2, what was the rationale for prescribing testosterone instead of, for example, letrozole or AI alone without testosterone?
I think that's probably twofold. Number one, I think testosterone has the beneficial effect on the tumor cells itself. So you're going to get testosterone when it fits into the androgen receptor will prevent proliferation and decrease growth. But probably the number one reason is to help these people with quality of life and symptom control. So I think it's twofold, both for tumor control, but also improving quality of life in these patients with breast cancer.
All right. Well, Dr. Glaser, we have a couple of questions, but we also have many congratulations and regards throughout all the presentation. Just so
Thank
you know.
you.
All right. So our next question for you is, have you used dihydrotestosterone for which AI would not be necessary?
No, I mean, I think that's a really great question, but I think there's much less data on DHT or dihydrotestosterone. And that's actually one thing we can block because of the cosmetic side effects. So I'm just more familiar with the testosterone. That's what we've gathered the data on. And I'm not sure dihydrotestosterone would work as well. There's also the question about dosing DHT. I think if someone wanted to investigate it, that would be excellent.
All right. And are these implants approved by EMA?
Are these implants, I'm sorry?
Are these implants approved by EMA? Maybe you can skip this. Is the I imagine is the European Medicines Agency, not EMAS.
Okay.
Okay, not EMAS, exactly. That's confusing.
Yeah, I'm not sure. I don't think so. I think we're trying to get approval here in the United States for the combination implant. Most places approve testosterone implants alone, and that's something that could possibly be combined with an oral aromatase inhibitor. It's just this method of delivery is so effective when you release both active ingredients simultaneously, and you have a far lower dose of the aromatase inhibitor, but we've shown that to be effective without the side effects. So I believe testosterone implants alone are approved, but I don't know that the combination is, but maybe that's something somebody should look at. I'm not familiar with EMA.
All right. So how to calculate the dose of testosterone and anastrozole for each patient? Another attendee was asking as well, anastrozole, letrozole, and testosterone. How do you calculate the dose?
Oh, 20 years of experience. But I think the one point is it's different for every patient and every disease state. If I have a patient that's 5 years out from a stage 1 breast cancer, she's going to need less aromatase inhibitor than somebody with active metastatic disease. So testosterone dosing is weight-based. So the heavier person is going to need a higher dose of testosterone in general. The dose of aromatase inhibitor, and I'm moving more towards anastrozole than letrozole, but the dose of the aromatase inhibitor depends on the disease state. So in these women with metastatic disease, where you have the tumor making aromatase, you do need the higher dose of aromatase inhibitor. And these women don't have side effects from it. So someone with minimal disease, and like that one patient where we had her on the higher dose of letrozole when she first presented with that 6 centimeter mass fixed to her chest wall, once that mass was gone, she started having symptoms from the aromatase inhibitor, and we were able to lower her dose because she no longer had that tumor producing aromatase. I have a protocol that I can share with anybody, but it is a clinical decision, and you're monitoring estradiol levels. So if you have someone on an aromatase inhibitor and their estradiol levels too high, you increase the aromatase inhibitor. But it's a clinical decision, but those are what it's based on. So disease state, I even have some breast cancer patients that are, low grade disease, 5 years out, and they can be on testosterone alone. So it depends on the patient, it depends on their weight, it depends on the disease state.
All right, our next question is, have you ever tried testosterone in hormone receptor negative patients?
Oh yeah, I do treat patients, breast cancer patients, and patients without breast cancer with testosterone therapy implants for quality of life. There is a possibility that in estrogen receptor positive patients, if they're androgen receptor positive, which is a very low percent, because most patients with androgen receptors also have estrogen receptor positive, that testosterone may be beneficial in a subgroup, but there's also concern if they're estrogen receptor negative, androgen receptor positive, and HER2 positive, that it might have a detrimental effect. That's just from cell cultures. Do you know what I mean? So I do treat estrogen receptor negative patients with testosterone therapy. And we've seen no adverse things, no adverse events. We've seen no disease recurrence. But testosterone also affects immune function, and this can help prevent cancer a recurrence from coming back. It increases bone density, it increases muscle mass. All these things that make you healthy, do you know what I mean, can help prevent disease from returning.
Our next question is, what is the frequency of these implants?
Oh, that depends on the patient. On average, it's about every 12 weeks. But when I have a large active tumor, I'm seeing them back at 8 or 9 weeks to begin with. That one patient, I now see back every 12 weeks when I initially saw her at 9-week intervals. A lot of times when I'm treating patients, they come back when their symptoms come back. So, and that can vary from patient to patient. So it could be 9 to 16 weeks. But when I'm treating active disease, I see those patients back a little bit more frequently.
All right. In the USA, are combo pellets available with finasteride in the USA?
No, none of these pellets are, we have them compounded. So we go to a special pharmacy and they make the pellets for us. So right now in the United States, these are compounded specifically with a doctor's order. Do you know what I mean? For a patient.
All right. Well, some comments of the audience. This is extremely impressive. Thank you. Thank you for such brilliant and very illuminating presentation. The audience is very happy, Dr. Glaser.
Oh, thank you.
All right. And the questions keep coming. The testosterone use is very high. Is that to contrast the effect of letrozole?
Yes. If you go back to the second or third slide in the presentation, the article on testosterone therapy in women with and without breast cancer, the rationale for dosing is there. Do you know what I mean? The rationale for combining it with an aromatase inhibitor is all explained, as are the levels on therapy and where they're expected to be. There's a wide range at you know, week 4. Do you know what I mean? There's a wide range when symptoms return, and that's very individualized per patient. So I think we've got to get past this idea of keeping levels within normative ranges for endogenous production, because that would not be effective therapy either in women with or without breast cancer. Remember, you're not just replacing testosterone when you treat someone with the testosterone implants. You're replacing that significant contribution from DHEA and androstenedione that contributes to over 80% of testosterone at the cellular level in female. So yes, you have to use the higher doses. The lower doses are ineffective. Even in our study, the 120 milligram dose was way too low to take care of aromatase-induced arthralgias. And yes, the ratio of testosterone to the aromatase inhibitor in the implant is 60-4, but that's not the total dose of testosterone. You go by symptom control, okay? You can't micromanage levels except for the estradiol level in breast cancer survivors. That's the one level I do manage. So I think that paper, for a lot of these questions, if you go back and get that paper, which is open access, that will explain a lot about dosing, not necessarily specific for breast cancer, but a lot of the dosing with regard to the testosterone pellet implant. So I think we've got to get rid of that idea. It doesn't even make clinical sense to keep testosterone levels below 70. That would never work because of basic physiology.
And why anastrozole instead of other AI?
Okay, anastrozole was the one I could get. That's the one that's more readily available. It's harder to get letrozole, but I was able to get some. I don't think there's a big difference. Initially, when I started doing this, there was some data that letrozole may be more potent in breast cancer. So that's why I initially treated some of the people with metastatic disease with letrozole, but I found that anastrozole works just as well, and it's actually easier to get.
Are there not androgynous side effects from the high doses of testosterone? How often do you administer the pellets? This is a question you already went through?
We administer the pellets. It's patient dependent, between 9 and 14 weeks, on average about 12 weeks. Different with different with breast cancer that's active. What was this other question?
If there are any
Side effects. Some of these women, the biggest side effects are the increase in facial hair and sometimes acne. But when you're looking at the benefits of testosterone, this, especially in breast cancer, this is irrelevant compared to side effects of chemotherapy and oral aromatase inhibitor therapy alone. And that's where we found adding the finasteride to prevent the conversion to DHT has significantly improved. We almost see no acne anymore. Do you know what I mean? They still do get the facial hair, but we offer laser hair removal. But it's not as bad as you think. They don't come with full beards. Most women start taking care of facial hair around age 35 or 40. So this is nothing new. Most women know what to do about it. And it doesn't stop patients from getting the testosterone therapy. And I think that combination with the finasteride has really helped that too.
Does this reduce or eliminate the need for chemotherapy?
I never tell a patient don't do chemotherapy. Patients come to me. Some of my patients do chemotherapy. Do you know what I mean? And they do the testosterone too. Do you know what I mean? Other patients do not want to take chemotherapy because they've weighed the benefits and the risk of chemotherapy, and that is their choice. So you can do it with chemotherapy. You can do it in place of chemotherapy. I do not ever recommend that to a patient. They come to me. Do you know what I mean? They seek me out because they don't want the chemotherapy. And that's, I still believe in freedom of choice.
Right. And what is the maximum testosterone peak level at 4 weeks if cosmetic issues are controlled? Does this influence your testosterone dosing, or is MRS the primary consideration?
Yes, you look at their symptoms. Do you know what I mean? And in that paper you'll read, and also our Constantine and my other paper on pharmacologic dosing for physiologic effect, you will read that a single level is almost meaningless. That can fluctuate hundreds of points within a minute's time. So, and when we look at our data at 4 weeks, there's a huge coefficient of variation for levels. So I never micromanage levels. Yes, I talk to the patient. We listen to their symptoms. We reduce the dose for side effects. We increase it for symptom control. So that was a great question.
All right. And do you provide progesterone as well?
I treat some patients with progesterone, not routinely. I treat them if they have possibly anxiety issues, problems sleeping. I might add progesterone, but with the higher doses of testosterone, not many women need it. But yes, I can prescribe progesterone, either oral micronized progesterone. I have put progesterone in pellets, especially for seizure activity, Parkinson's disease, or where there may be an additional benefit to progesterone.
We have a couple of more questions. Do you use this combination in family history of breast cancer as a preventive treatment?
Oh, yeah, that's a great question. Yeah, if you have a strong family history of breast cancer, we can, and you want testosterone therapy, we usually combine it with the lower dose of anastrozole, just 4 milligrams. We follow estrogen, and I think we do see a reduced incidence of breast cancer. Of course, I tell everyone to eat healthy. So yeah, I think this could be a preventive measure for strong family history of breast cancer, on top of testosterone alone.
And have you found that pellet therapy improves insulin sensitivity?
Oh, yes, I have found that in female patients and male patients. In fact, sometimes they monitor their glucose, and towards the end of pellets, it gets worse. In the beginning, it gets better. So yes, I have found that, just like they've done the studies in men. I don't have enough data to publish, but clinically, that is what I see.
Right. Outside the clinical setting of breast cancer, but given the beneficial effects of testosterone in breast cancer, does adding testosterone to standard HRT in menopausal women decrease the risk of breast cancer in general population?
That's what Rosie Jones and Constantine's data showed. When they added testosterone pellet implants to conventional therapy, it did decrease the risk of breast cancer. So that was some original work by my research partner.
And our last question for today's session is, when do you decide to place the implant into the tumor or in gluteus?
Okay, part of that depends on patient preference. If they have metastatic disease or disease that has spread outside the breast, there's no reason to put it around the tumor. If their tumor's isolated to the breast, you might want to put it around the tumor, theoretically, to get those higher levels of both testosterone and the aromatase inhibitor to the tumor. But it still works if you put it in the gluteal area. I'll put it in the gluteal area if they're still going to undergo conventional therapy, because you may see it on MRI, you could see the pellet, you might see it on ultrasound, and that really confuses other people. So if they've got tumor in the breast alone and no evidence of metastatic disease, I would offer to put it in the breast tissue.
All right, thank you so much, Dr. Glaser, for an amazing Q&A session. Any final thoughts before ending today's presentation? No. The audience is very grateful, I gotta say. Comments still coming.
I am very grateful to the audience for taking their time on a Saturday. Thank you.
All right. And this concludes the webinar. Again, thank you so much, Dr. Glaser, for an amazing presentation, and all the attendees for being here today. Have a great rest of the day.
Thank you, Lena.